When I meet a patient for the first time, the first and most important thing is to listen to their story and take a history, see what it is that's bothering them, what caused the injury, is it chronic, is it acute, that kind of thing. And so much of the time, 90% of the diagnosis is in the story that the patient tells us. And then, we always want to get some imaging to help complete that picture, help sort of solve that mystery for the patient and do a physical exam. So usually the initial imaging is just an x-ray, and that'll help us rule out things like arthritis or fractures. And then the physical exam, gives us another piece of that picture. Once we've done that in our first initial visit, I can give the patient an idea about what I think their diagnosis is and what their prognosis is. If there are non-operative treatments available that are likely to make this patient happy and do well, we'll always discuss that and go down that path first. If this is clearly a situation where we need more advanced imaging, something like an MRI to help make decisions, we'll often get an additional study. And then, depending on what those images show, if there's anything that's likely to benefit from surgical repair or treatment, we present those options, and it's always a shared decision-making model. When I meet a new patient that's a child, it's accompanied by a parent or a guardian typically, that decision-making and process is a little bit more complicated. I think it's really important to address the child as the patient and get their story and their history and learn about what's important to them, but also important to educate the parents and hear their perspective about what's been going on, and have a discussion with the child and their parent or guardian so that everyone's on the same page.